We're back on live with Dr. Michael Pineda. So the next topic is about New York strong COVID experience in the Big Apple by Dr. Mike. So Dr. Mike was a member of AMSA Philippines and currently a neurology resident at the Montevideo Medical Center in New York City. He got his medical doctor degree from the University of the Philippines and MSc in Life Sciences in Kyoto University. He would like to share his experience living in New York City during the pandemic, how the healthcare system coped, and how the locals were able to lower infection rates despite the challenges. So, Dr. Debbie, do you want to introduce more about Dr. Mike?
Course, yes. I just want to say that one liner I said earlier. You know that every day, not quite every day, but a few times in a week, I would be looking at my phone and suddenly laugh out loud. And thankfully, I'm not like driving or something when I'm looking at it because the laughter actually caused by Dr. Mike Pineda's posting usually because he is the most wonderful postings ever. And like this morning, my whole family was laughing at it. And I think that you have the real gift of the tongue. You have the real gift of speech, Mike. So Mike, thank you so much for the laughters and the happiness that you spread. Now,
Well, you're welcome. Okay, so am I on? Hello,
Yes, doc-
everyone. Hello, everyone. It's hard to know how many people are here, but I was browsing through the attendees, and we have quite a number of people here. So for this talk, before I start, I did actually prepare. I got these earphones on. I look like Princess Leia. I look like a Twitch streamer, and I had my apartment cleaned. So I hired someone to clean my apartment, which kind of like embarrassed me a little bit because I feel that I failed as an adult because I can't balance chores and work and my personal life. So I cleaned up a little bit before the cleaner arrived. So there's that. All right, so let's start. So my talk is a little bit similar to Dr. Michael's talk earlier, but it's complementary to what he talked about. I will be going through my experience. So this is gonna be personal, not in a I'm not going to talk about neurology. If I do, it's only going to be circumstantial to the topic at hand. So I'm going to share what has happened in the Big Apple, um, in New York City. I mean, a lot of my friends send messages of concern that how are you doing and are things going better in New York. I thought at first that it was mostly out of concern, and it for the most part it is. But I guess that it's also worth talking about because just in case you ever get into a situation that's similar to New York, you as healthcare professionals kind of like know what your other colleagues have gone through, so that learn from another person's experience. All right. So is my PowerPoint on? All right. So the first slide is so I'm gonna talk about experience in New York. So my first slide is the who. So I'm gonna tell a story: who, what, when, where, and the who, where, what, and why. So I'm gonna start with who I am. I am Michael Pineda. I am originally from AMSA. I am from AMSA Philippines, and I was active from 2009 to 2011. I dabbled a little bit outside of medicine after I graduated from med school, and then I returned to clinical training, and I'm now a neurology resident at Montefiore Medical Center. It's a hospital in New York City in the Bronx. So that's me, and I love the brain. That's why I became a neurology resident. So the next slide is the where. So where is this story happening? So for those who are unfamiliar with what New York City looks like, most of what you saw on TV, like Friends, Sex and the City, all that stuff, Avengers, most of it actually happens in Manhattan. But New York is more than just Manhattan. New York actually has five boroughs. In the north, where I work at, is you have the Bronx, and you have Queens and Brooklyn on the east. And on the south, if you notice, There's like a purple island that's not disconnected from the rest of the boroughs, and that's Staten Island. To get there, you're gonna have to use the ferry. So that's where the story is going to happen. Mostly, I live in Manhattan in the northern tip. You see that green tip over there abutting the Bronx? That's where I live. And I just cross the bridge to get to my work on the eastern side. So that's essentially how I where I work at. When I explain neurological diseases to my patient, I actually use geography. I say, the brainstem is very important. That's where breathing, the heart rate is controlled, consciousness is controlled, and it's like a narrow area. It's kind of like Manhattan. It's where all the important stuff is going on. All the restaurants and the parks and the universities are in Manhattan. And then it kind of like spreads out into a greater area, which is the Bronx. So that's kind of like that's kind of like how I explain geography or neuroanatomy to students. All right, then. Let's move on to when. Which period of time am I talking about here? So I know you probably heard in the news that around March, New York, March to May, New York kind of like suffered through a spike in COVID cases that momentarily overwhelmed our healthcare system. And I'm just gonna be talking about that time and up until the current time, but most of my talk is going to be during the peaks in April and May. So that those are the setting, the characters, and the scope of what I'm gonna talk about. Then I am gonna proceed with my story. So the what? Next slide, please. All right, so this is a picture that I had earlier this year. Next slide, please. The what? Right. Yeah, so that picture, I'm going to start my story with this picture. So this picture was taken during Chinese New Year. I believe it was February. And during Chinese New Year, what I do is come down to Chinatown and have some Chinese food. My comfort food, my favorite food, my comfort food is shrimp dumpling, hakao. We call it hakao. I love it. So I invited my co-residents. So the other people in this picture are my co-residents. And I kind of convinced them to join me and have a little bit of dumpling to celebrate the opening of the Year of the Rat. And during our table conversation, there are three salient things that kind of like foreshadowed things that are about to come. The lady on your left, your most immediate front left, her name is Sophia. She's my coworker, and she's from Taiwan. So she came from Taiwan, grew up there up until high school, then did her college in the U.S. and her medical school. And it really took her a while before she was convinced to come to Chinatown, because at that time we already know about cases of new coronavirus circulating around Asia. And she said that, you know, I have experience in the SARS outbreak in 2003, and I think it's gonna go bad. So let's not go to Chinatown because New York is a big and crowded city. We may be able to catch it or something. And I was like, uh, nah, I mean, it's not, we don't have any cases yet, and we'll take some precautions. Um, so I know I was kind of like foolish at that time. And also I do kind of like have a little bit of experience as well. The Philippines never really got the brunt of the SARS coronavirus outbreak as much as, let's say, Taiwan or Hong Kong, but we kind of gotten through the H1N1 influenza in 2009. And I have like a really flashbulb memory on that, because that was my first conference with AMSA. It was in Taipei, and we were a big group, and some of the attendees tested positive for H1N1. So we were quarantined for a time in Taipei. And the great thing about that was that the Taiwanese government was pretty supportive. They kind of like gave us our Tamiflu doses and led us through. It was scary, but we got through it. And I thought that that's how things are gonna play out. You know, yes, it's concerning, but it wouldn't really stop life. That was my thought. And in retrospect, now I kind of like think it's kind of silly. Please feel free to butt in. I mean, I am telling a story. Like anyone who tells a story, you can always ask a question before I move on to the next point. You know. The second point that we kind of like talked about in this dinner table is how 2020 is gonna be our year. You know. In the year 2020, we have so much plans. We're entering the final year of our residency training, and we're like talking about traveling. And I said I want to go back to Asia and like see my family and friends, and maybe travel nearby countries. And I signed up for the New York City Marathon and all these sporting events. And like, yeah, I have more time. I'm gonna like enjoy the year 2020. So now the third one is that we did talk about coronavirus for a time, and we were like making predictions what will happen if it ever hits New York. Our thought that it's not a matter of why it's not a matter it's only a matter of time before we get the first cases. We didn't really think that we would be immune, but we thought that once it happens, we're going to be ready, and we're going to be prepared because our hospital had some experience with outbreaks. And during the Ebola outbreak, there were some assigned rooms actually in the hospital that was funded by the federal government where we can have patients in quarantine. But I really didn't expect at this time what's going to happen. So let's move on to the next slide and see. So I don't know if you've heard it on the news, but it was a really terrible 2 or 3 months for the people of New York. On March 1st, we recorded our first COVID-19 case, and it kind of like hit me personally because the hospital where it was recorded was in the hospital I did my internship. So in neurology training, your first year of residency is internship. So all I do is internal medicine for the first year, and then I go to neurology proper. So I did my internship in a suburb of New York called Westchester. It's in New Rochelle. They found one case, just one. It was actually someone in the community, and the person is not in any way of Asian descent. It's just out of the blue because the patient never really had travel history from Asia. Um, so they weren't able to make that connection immediately. But later on, the patient tested positive for coronavirus, and then that's how it made the news. Just to say that how surprising it was, the gentleman was actually a religious leader from a country very far from Asia. And so we were like, where did this come from then? And we were kind of like concerned that the containing this containing this outbreak in terms of contact tracing is going to be impossible because we think that it has already spread far and wide. So we recorded our first case in March 1. And then the week after that, we were getting a lot of more cases. The first case recorded in the city was in the Bronx, the area where I was in. And some came out in Brooklyn, and then it's just started popping up. I don't know if you play the game, on your mobile games. I don't know if you know a game called Plague Incorporated. So the game is kind of like pretty morbid. The objective of the game is to infect everyone in the world. You start with one country, and then once your bacteria or your virus picks up infection, um, things will like there will be like infection bubbles popping up all over the world map. That's essentially what happened in New York between March 1 to the third week of March. We were getting so many cases of infection. But at this time, our healthcare system is already starting to feel the brunt of the pandemic. So what this means is that normally, if you have a patient with respiratory distress, the first person who's going to see them is the emergency doctor. And I think later on, we'll have someone in the critical care field who'll talk about COVID. So I'm not going to talk about that because that's not my area of expertise. And then, depending on what their disease course is going to be, they'll either go to the ICU or go to the medical floor, depending on how stable they are. And for the most part, these are staffed by internists or pulmonologists or critical care doctors. But at that time, we were already having so many cases that they're already overflowing into other units, like the pediatric unit, or already starting having adults, young adults, 18 to 21, showing signs of COVID. In the third week, um, in the third week, March 22, the entire state of New York was put on pause. Everything was closed. At the start, it only took 3 days. I remember that after work, I went to a restaurant, and Cuomo, the governor of New York, was like saying we should only have 50% capacity in the restaurants. But then the following day, everything closed down. And so that's that. The third week, New York State was on pause and became a really, really sick city. And at the time, the United States sick city. But one thing that I would like to point out is that New York is not the first state that had COVID cases in the U.S. At the time when we were having dinner for Chinese New Year in February, there were already cases in Washington State. In Washington State is not the same as Washington D.C. Washington State is in the West Coast. It's north of California, and there are only a few cases that were recorded there. And at that time, I thought that it kind of like gave me this complacency that, oh, this is gonna end up like H1N1, where we had cases, but then it suddenly, kind of like the pandemic, the outbreak kind of like burned itself out, and then that's it. But that wasn't the case at all. So next slide, please. Then I'll talk about what was the hospital response. So at this time, when we were already getting so much overflows, each staff were pretty concerned. I, as a neurology resident, I'm already past the phase of my training where I see patients with pulmonary symptoms. I am already like, I'm just seeing mostly neurologic consults. So strokes, epilepsy, Guillain-Barré syndrome, peripheral nerve emergencies, those are the cases that I see. If you make me adjust a patient's ventilator, I don't know. I seriously won't know what to do. So the hospital response is that, okay, if things go from bad to worse, we're going to go for phase one. We will ask for volunteers to staff the COVID tents, the floors in the ICU. So what are the tents? COVID tents are areas set up outside the emergency department, and these are for patients who are suspected to have COVID symptoms. And your job in these COVID tents is to do the swabs. It's kind of like risky work if you think about it, but that's one. And then there are the floors. These are COVID patients who are a little bit stable. And then you have the ICU, the patients who are not that stable. Unfortunately, during the course of the outbreak in New York, we were kind of overwhelmed at phase one. Our floors weren't enough. So they had to use the children's hospital as a temporary adult floor. And we're talking about like 8 floors of pediatric floor given only for adult patients. And then, more importantly, we're running out of ICUs. At the start, it was the ICU, our medical ICU, neurosurgical ICU, cardiac ICU, all specialty ICUs became medical ICUs. And then later on, all elective procedures, surgical procedures were canceled all over the state, and our operating rooms became temporary ICUs. And I think that something similar happened in Italy. And then later on, step down units became ICU. Now, we have to commend how hospitals were able to do this, but at the same time, it's not perfect because, as you know, ICUs are specially designed for cases like this. Think about like makeshift ICUs or ICUs or like step down units that suddenly became ICU. They don't even have proper filters yet, so they had to be constructed. They have to like install the filter quickly. Um, so it was quite a challenge, and also the staff. ICU nurses are different from floor nurses, and you can only have a couple of ICU nurses. So some floor nurses had to work in the ICU, and they were very uncomfortable about this. And what this means is that for us doctors, whereas ICU nurses, for example, can do procedures, floor nurses sometimes are uncomfortable, let's say putting IV pushes or starting drips. So we have to do it ourselves as well. So phase two. So for phase one, I did volunteer. I was one of the first residents in my department who said, "All right, fine. I mean, we're already in that point, and I don't think there's no way out of this. We're just gonna have to really get pulled out and deploy in these COVID floors." Um, because and I did that because back home the Philippines was also suffering from COVID outbreak, and a couple of my mentors, professors, and even my co-intern when I was doing medical training there kind of passed because of COVID, and it didn't really feel right for me to just sit back and like, all right, we don't have any neurologic cases, so I went there and did did the COVID work. So at phase two, we kind of like reached phase through phase two. Some residents were pulled out and deployed in the ICU floors or tents, taking care of COVID. Unlike Dr. Michael, our hospital remained as a hospital, seeing other cases, but majority of our cases are still COVID. I was assigned to one of the makeshift ICUs. Um, and it was very difficult because at first I thought that this is just going to be a pulmonary problem. I know this is early April. I didn't know any better. Okay. So I was reviewing how to adjust the vents, and I was reading through the pulmonary module of reviewer books, and I'm like, all right, I got this. I did internship in the Philippines. I did internship in Westchester. I'm gonna do this. I can do this. I'm always gonna be a doctor. And but in the actuality, I got overwhelmed by the task because it's not just the breathing issue. It was also, well, like, why is this patient suddenly having AKI, or why is this patient having sugars in the 500 despite not being a diabetic? There are so many things going on, that the patients are going into multi-system failure that I didn't know why, and it was very challenging. But right now, I think that we already know that COVID is not just a respiratory issue, but more of like a hematologic issue. That these end organ damages are happening because of small vessel thrombosis, and at that time, our treatment was kind of like the wild wild west. We were still giving hydroxychloroquine. We were enrolling patients left and right to different interleukin 6 biologicals, interleukin 6 inhibitors, and hoping for the best, what sticks. The medical part was challenging enough, but one of the most difficult part of the entire ordeal for me was the social part, because the patients that I deal with were intubated patients going into multi-organ failure. How do I explain to patients, families, that the father or the brother or the grandfather they saw alive and well just 2 days ago came into rapid respiratory failure yesterday and now have to undergo dialysis and insulin drip because they suddenly had AKI and uncontrollable hyperglycemia? I mean, sometimes, and these patients' families are not able to see their relatives. So it's also about how, explaining one thing is different than making them understand, because to them this is all abstract. Like, what are you talking about? My father was just okay 2 days ago, and now you're telling me that my father is dying. And the families kind of understand that these are unusual circumstances, but people are people. Humans are being humans, and sometimes they direct their frustration at me or anyone in the healthcare team. And all we need to do is understanding. So these ICU shifts are pretty long. They last for 12 to 13 hours. And by the time I reach home, I'm just like super drained and overly, emotional. Also, I am alone in the city. I'm not really from New York City. I'm from the Philippines. So you kind of like think about, okay, this is a very lonely time for everyone because we're socially isolating and also people are dying alone. And so, similar to what Dr. Michael was alluding to earlier, we do have a support system for residents, and I was availing of it. Tuesdays and Fridays, I was calling the psych department and was like, I need to process this because I had a patient who just passed away. To give you an example of one event that really got to me was that there was this gentleman who was about to die, multi-organ failure. We cannot stop the dying process, and that's what I've been telling the family. And they decided to take out the tube, but of course they cannot visit. It's the height of the pandemic. It's not safe. So what I did, I put my phone in a bio bag, called five of his children all over the country, different states, California, Alabama, Georgia, you know, from all over the US. Put the phone beside the patient's bed, and I told them, you can say goodbye before we pull out the tube. And they were saying, we love you, Dad. Bye, bye, bye. And when during this thing, the patient suddenly had this like elevated heart rate and blood pressure, as if like he understood. I don't know. It just really got to me, or maybe it was just I was just super stressed that I kind of like cried at the patient's bedside. Thankfully, or maybe not. Again, I was alone. Nobody saw me cry, but it just captured the mood at that time. It was kind of like um, and before we pulled out the chew, I was like telling the patient, I'm sorry that you had to die or you have to pass this world without your family, but at least what I can do for you is you're not gonna die alone. So we pulled out the tube, but he held on for 2 days and then he passed away. So that story kind of like played out a couple of more times for me, and so it was kind of like really draining. um, in neurology, we do have cases like this that we see, sudden stroke patients. So it's not something that I don't have experience with, but um, for this to happen day in and day out, and most of my patients, is kind of like sometimes draining. And out of the 20 patients I did see in the ICU, none of them made it. They all passed. Some of them did make it out of the ICU, but they just stayed too long in the ICU that they later on developed a lot of complications and they passed. So and every day during the days that we were undergoing this, I was looking at the graph, like how many more days of hell are I gonna suffer through? How many more days? And next slide, please. So around March, April, May was my time of deployment in the ICU. I kind of like stayed in the ICU for that long. And that was even the worst of it. Most of the New York City cases, most of the New York City mortalities due to COVID were actually in nursing homes. And so I had friends who had same experience as I did, but their patients were dying left and right, like 5, 6 deaths per day, and it was that bad. Um, and so the rest of the city was kind of like in a stand down. What the thing I respect about New Yorkers is that despite what you see on television, like how Americans like protest mask and all that, the people of New York took this seriously. During the height of the pandemic, a lot of New Yorkers were really in their homes. Younger people were volunteering to buy groceries or run errands for the elderly members of their community, and not a lot of people were using the subway and the bus. There is a high usage of mask, despite mask at that time being just a suggestion. And I think through the efforts of New York, of the people of New York, we were able to bring down our cases, and until by June, things started feeling normal. I remember So my birthday is around the first week of June, and like I was like, oh no, I'm gonna spend my birthday in the ICU. I receive an email from my director, my boss, saying, you don't have to go back to the ICU. I'm giving you a week of rest, and you're going back to the department. And I was so happy. For that 1 week, I was just at home. I was binge watching Netflix, and I was playing video games. And the following week, I returned to work as a neurologist. And that's that. And actually, up until now, as you can see from the graph, we are doing quite well. The only thing though that I am afraid of is that a second wave could be up and coming by fall or winter. And especially if influenza season comes in, it's gonna be horrible. We won't know who has COVID, who will not have COVID. Next slide,
Dr.
please.
Mike, yes,
Uh-huh.
I'm so sorry to say, but yeah, your time is out.
Done.
Yeah.
Okay, that's fine. I actually am already finished because I'm already
Okay.
like in the climax, and then that's it.
I'm so sorry,
All
Dr.
right. No, that's okay.
Okay. Yeah. So, do you want to continue your last slide? Probably, Dr.
Yeah.
Mike.
Yes, please. Yeah. One, maybe a minute, a hot minute. So, um, yeah. So there is hope. I guess that's the only thing that I would say. From June to the present day, New York City has opened in phases, from phase one to the end phase, and a lot of people are enjoying the summer, going out and dining out. But there is still this lingering sense of things haven't really returned to normal, pre-COVID normal yet, and their New Yorkers are still kind of vigilant about how things are gonna go on. So yeah, so I just want to end in a positive note. And that's it. Thank you.
Thank you so much, Dr. Mike. We're so sorry about the time. Thank you for your amazing presentation, Dr. Mike. So, I think you can answer one question from Dr. Ong. Okay, Dr. Ong asked,
Hmm.
being able to experience both the status of healthcare in your home country and in New York,
Mm.
is it better politically safe to say that physicians have better monetary or hazard compensation there compared to
Ooh,
those
hmm.
who practice in Asia?
It's gonna be tricky comparing US with Asia, because Asia in itself is a very heterogeneous region. I would say from my training in the Philippines that it's still better in the US in terms of how we were provided with PPEs and compensation. We did receive, and to answer Dr. Ong's question, we did receive compensation. By the end of this, we receive a one-time bonus that kind of like covers the month that I was in the ICU. uh, but in other areas in Asia, I think that things are actually better. You don't even have to be a first world country in Asia. For example, Vietnam, in Malaysia. I'm not sure about Malaysia, but probably still did better than the US. Even still did better than New York. So, but my home country, I wouldn't. I'm sorry, my fellow Filipinos. I wouldn't say that we actually did a better job than what we did in the US. And I hope that things get better at home. I am really worried.
Yeah. Okay, Dr. Michael, we have one follow-up question from Dr. Dr. John, Dr. Ong.
Hmm.
So, the question is, and by you volunteering there, were you entitled to receive hazard pay and compensation as well, or as a
Yes, yeah.
okay?
Yeah, we did receive a one-time bonus during the end of this. We received it around June, and I kind of like felt that it was fair. Other residents didn't feel it was fair because it was essentially risking our life and beyond our like mandate. Because if you're a neurologist, why are you like taking care of vent patients? But my opinion is that it was okay. But it was, if you look at like news items from from April and May, there it had been a controversy in some hospitals with some attendings and some hospital administrators saying you signed up for this. And thankfully, my hospital didn't have that attitude, and so I'm kind of like thankful about that.
Okay, great. Thank you so much, Dr. Mike, for your time. So, attendees, if you have any more questions, I think, are they allowed to send you direct message, Dr. Mike? Dr.
Of course, yes,
Okay.
please. I'll be hanging on until 10 o'clock.
Oh, wow.
Sorry,
Okay.
I have something to do
It's
for the
okay,
day,
Dr.
but
It's okay, Dr. Mike. Okay, I think that's all for this session. Thank you so much, Dr. Mike, for your amazing presentation.